The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Now let's proceed to discussing your gastrointestinal pharmacology. So although this is a relatively simple topic, it is one that is always quite heavily tested in the board. So do make sure that you go through these quite well. Let's start by discussing the drugs used for your peptic ulcer disease or your PUD. So from the name itself, P-peptic, it pertains to the chronic exposure of the U or the ulcer in the gastrointestinal tract to acid peptic juices. So this, of course, leads to symptoms like dyspepsia, nausea, vomiting, abdominal pain. And when severe, it can cause GI bleeding, or when even more severe, it can cause perforation, which can be, of course, fatal. Now, to review the drugs that we use for PUD, I always like starting my discussions on drugs by showing you a figure so you understand where the drugs act and why they do what they do. So first, let's go into how the stomach even starts secreting acid in the first place. So let's orient ourselves. We have here the parietal cell, which we know contains the very important proton pump, which is your hydrogen potassium ATPase. Okay, that is your proton pump. And that is what excretes or secretes hydrogen into your into your stomach in order to produce acid. And then we have your superficial epithelial cell. And we know that these superficial epithelial cells help to maintain the mucus layer, which is maintained at a relatively neutral pH of 7 because it has mucus and bicarbonate to help neutralize the gastric lumen, which is at a pH of 2, and to prevent any erosion and damage towards the epithelial cells. So we have the acid secretor and the superficial epithelial cell protecting the gastric layer. Now let's go into how the proton pump is triggered to work, or how it starts to secrete hydrogen into your gastric lumen. So number one, let's look at the M3 receptor, or one of your muscarinic receptors. When acetylcholine, remember acetylcholine is released during parasympathetic processes, because your parasympathetic processes are stimulated when you rest and digest, diba? So sympathetic is fight or flight, and parasympathetic is rest or digest. So you have acetylcholine attaching to your M3 receptors. This then causes activation of your hydrogen potassium ATPase, therefore increasing its activity, therefore increasing the acidity inside your stomach. Next, we have acetylcholine acting on different parts of, or on different cells as well. So when acetylcholine activates your ENS neurons, okay, this then causes activation of your ECL cell. What is your ECL cell? That is your enterochromaffin-like cell. So acetylcholine triggers this to release histamine, okay? And histamine attaches to the H2 receptor in the stomach lining as well. And this, again, via a CAMP-dependent pathway, causes an increase of acid secretion. What else does acetylcholine act on? It is also able to act on the bombesin, BOMBESIN receptor of your G cells. And what do the G cells produce? They produce gastrin, which is the most potent inducer of acid secretion. So gastrin attaches to CCKB, cholecystokinin B receptor, and this again triggers the release of histamine, which again triggers the secretion of more acid into the system. So we can see that by inhibiting either the muscarinic receptors, the histamine receptors, or the proton pump itself, we can inhibit the amount of acid that is secreted into the gastric lumen. And pretty much that's it. That's what I'm going to discuss in the next few slides, but it all goes back to this picture. So let's start by first discussing the weakest and the least effective out of all the drugs for PUD, and those are your antacids. So the reason we still have antacids, despite them being less effective than everything else, is they are cheap, they're accessible, they act quite rapidly, and they're simply over the counter. So marami na siguro sa atin naglaklak ng Gaviscon Forte after drinking coffee during an all-nighter or going out to drink, and we know that it is quite effective. So we give magnesium hydroxide and aluminum hydroxide as well as calcium carbonate to neutralize the excess hydrogen or acid in the stomach. And one thing in terms of the side effects that we need to note, so especially with magnesium and aluminum, is Mg for magtatae, okay? Magnesium hydroxide is known to cause diarrhea, whereas ayaw lumabas, can cause constipation, okay? So magnesium can cause diarrhea and aluminum hydroxide can cause constipation. Aluminum hydroxide can also cause other side effects like hypophosphatemia, osteodystrophy, and proximal muscle weakness when taken in excess. Okay. So why do they cause diarrhea and constipation respectively? So your magnesium, what happens is it promotes smooth muscle contractions. So therefore it promotes peristalsis, and therefore you have an excess of peristalsis, and therefore you get diarrhea. The opposite happens with aluminum hydroxide. It promotes relaxation of your gastric smooth muscle. So relaxed gastric smooth muscle equals walang peristalsis equals delayed gastric emptying equals constipation. So all of these antacids will also typically contain an agent called simethicone, okay? And that's an anti-foaming agent, which lessens the gassy or reflux symptoms of PUD. Now, calcium carbonate is not as commonly used anymore, and this is because of its association with milk alkali syndrome, or MAS. So what happens in milk alkali syndrome? Essentially, when you ingest excessive quantities of calcium and absorbable alkali, this causes metabolic alkalosis and hypercalcemia plus kidney injury. So alkalosis, hypercalcemia, and kidney injury. They also found that in the past, it was also associated with hyperphosphatemia. And this is because in the past, this calcium carbonate was mixed inside milk, and milk contained a lot of phosphate. So milk alkali syndrome was typically associated with hypercalcemia, hyperphosphatemia, and renal calcinosis. Though now, since we don't mix it in milk anymore, the hyperphosphatemia may not be as noticed anymore. It can also result in rebound hyperacidity, which is a stronger rebound of the symptoms after it initially being resolved with giving calcium carbonate. So all of these antacids can also impair your absorption of your tetracyclines, your fluoroquinolones, and your iron. Remember, with tetracyclines, we advise not to drink with milk because it impairs the absorption of this drug. So those are your least effective but quickest and easiest to access drugs for PUD. Next, we go into your H2 receptor antagonist. So we remember that histamine via the H2 receptor on the parietal cells, this is able to promote the action of your proton pump or your hydrogen potassium ATPase. Okay. Now, H2 receptor antagonists are mostly used to help heal gastric and duodenal ulcers. They are less effective than PPIs, but they are very good at suppressing nocturnal acid secretion, meaning at night, the acid secretion is reduced by up to about 70% with the use of your H2 receptor antagonists. Now, its effect in meal-stimulated acid secretion is less effective. So it's only moderately effective versus your PPIs, which are more effective in that regard. So what are the examples of your H2 receptor antagonists? So they all end in idine. So cimetidine, ranitidine, famotidine. Okay. What are some side effects that you guys need to know? Generally, they're all quite well tolerated. The side effects that you guys need to note for the boards is with cimetidine in particular, it's a potent inhibitor of your CYP450. Okay, it's an inhibitor of your CYP450. And it can cause what we call gynecomastia. All H2 receptor antagonists are also associated with an increased risk of nosocomial pneumonia. Another thing you guys need to know is, although it is very well tolerated most of the time, whenever it does have side effects, it's usually seen in elderly patients, especially when you give H2 receptor antagonists IV. So what are some side effects that we can see in elderly patients? There are typically CNS side effects. So some of them can present with confusion, delirium, etc. But again, these are rare and only particularly seen in elderly patients given IV H2 receptor antagonists. Next, we have your proton pump inhibitors, which are the most potent suppressors of your gastric acid secretion. So whereas your H2 receptor antagonists are best at inhibiting acid secretion overnight, and even when they do it overnight, it's only about a 70% reduction. PPIs cause an 80 to 95% reduction in both overnight acid production and also stimulated acid secretion, meaning after meals. How do they do this? They do this by binding irreversibly to your proton pump or your hydrogen potassium ATPase. So what does it mean when they bind irreversibly, Doc? Essentially, the only way to replenish or to resume acid secretion whenever you've already blocked the proton pumps is to synthesize new pump molecules. So you can imagine that would take the body quite some time to do this. Remember that in the photo I showed you guys, this hydrogen pump, this acid pump is the last step. So even if you increase the gastrin, even if you increase the histamine, even if you really overstimulate the acetylcholine, kung wala yung exit door by which hydrogen can exit, kung wala yung pump by which hydrogen is secreted into the lumen, there's no point. That's why it's so effective, even in the presence of rebound hypergastrinemia. What is rebound hypergastrinemia? It's essentially an increase in your gastrin levels because it's noticed na nagiging basic yung inyong gastric lumen. Pero again, even if it increases more and more gastrin, medyo walang effect because you've blocked the last step of the proton pump or of the acid secretion. Now, one thing you need to know about PPIs as well in terms of its pharmacokinetics is it's actually a prodrug when you ingest it, and it is activated in an acidic environment. Another thing you need to know, remember, whenever we advise patients to take a PPI like omeprazole, we advise them to take it 15 to 30 minutes before breakfast in the morning. So why do we do it in the morning? The reason is because it's most effective in the morning kasi in the morning, your proton pump increases after fasting. So, diba, when you sleep for 8 to 9 hours, pero kung med student ka, maybe 3 to 4 hours lang. But ideally, if we sleep over 8 to 9 hours, for example, the number of proton pumps actually increase in our stomach. Therefore, first thing in the morning when you take it, and before you have food, you already maximally blocking all those proton pumps. And therefore, it becomes very, very effective throughout the whole day. Now, I mentioned that the PPIs are activated in the stomach. Where are they absorbed? So they are not activated, they are not absorbed in the stomach, they are absorbed in the small bowel. So again, activated in the stomach, absorbed in the small intestines. Okay, so that's important to note. Please take note of that. It is not, however, a completely safe drug. There are also side effects, especially with very chronic use. So what are some side effects? One thing you guys need to know is fragility fractures, especially in elderly patients. Chronic PPI exposure is associated with bone fractures and also HAP, or hospital-acquired pneumonia, surprisingly enough. It is also associated with certain infections. So again, HAP and enteric infections, particularly your community C. diff infections. Okay, so PPIs are associated with HAP and community C. diff infections, and SBP, or spontaneous bacterial peritonitis in patients with ascites. It can also cause malabsorption, particularly of your vitamin B12. And again, like I said, it can cause hypergastrinemia because nagkaka-negative feedback, therefore gastrin goes up. Okay, so very, very important to remember your proton pump inhibitors. So we've discussed the drugs that will stop the proton pump from secreting more acid. We've discussed the antacids, whereby it doesn't really do anything with the mechanism, but it helps neutralize the acidic contents of the stomach. We've discussed the proton pump inhibitors, which are the most effective. We've discussed the histamine antagonists, H2 antagonists, your cimetidine, ranitidine, famotidine. Now let's discuss the other drugs used in the treatment of your PUD, particularly your mucosal protective agents. So let's say meron ka ng ulcer or meron ka ng erosion of your gastric lining. What drugs can we give to protect the mucosa? Next, we'll talk about your mucosal protective agents. So the drugs we discussed previously would affect the biologic function of your proton pump. Here naman, this is just a physical agent. So imagine this is your gastric lining and you have a shallow ulcer or an erosion. What it does is it literally just forms a physical barrier, a physical polymerized barrier to act as a protective agent between the erosion, which is trying to heal, and the acidic contents of your gastric lumen. So how does it do it? It is believed that these are negatively charged. So your sucralfate and your bismuth salicylate are negatively charged, and they bind to the positively charged proteins present in the base of ulcers and erosions. So it forms a physical barrier, it restricts further caustic damage, and it also is believed to stimulate mucosal prostaglandin and bicarbonate secretion, which we know are protective factors in your gastric lining. What are some special things about these drugs? So sucralfate is highly insoluble, meaning it doesn't get absorbed into your systemic circulation and really has very few side effects. However, it is washed away quite quickly after meals. Therefore, nawawala yung physical layer of protection. So it requires frequent dosing, which can be quite inconvenient. Your bismuth salicylate naman also has the additional benefit of having what they perceive to be direct antimicrobial effects, which is very good, especially in the presence of your H. pylori, because we know that that can worsen peptic ulcer disease. It also has the same benefit of stimulating prostaglandin and mucus secretion. It does have some side effects, and that one of the side effects known is darkening of the tongue, as we can see here. So this is a patient who was on bismuth salicylate, came in with a chief complaint of darkening of tongue, and it was because it is a known side effect of bismuth. It is also sometimes used in acute gastroenteritis because it has been shown to reduce the stool frequency in TGE. Now, I discussed this in the NSAID chapter, but I remember that NSAIDs, what they do is they decrease the production or they inhibit cyclooxygenase, therefore decreasing the production of your prostaglandins. Prostaglandins, however, are very important in maintaining your mucosal lining. So whenever you have NSAID-induced gastritis, the best medication for it is actually misoprostol, because misoprostol is a prostaglandin agonist. Because you're reducing the amount of prostaglandins in your stomach, you have to replace it in order to maintain the integrity of your stomach lining. So it increases bicarbonate and mucus secretion in the stomach, but the side effect, quite significant side effect, is also diarrhea. Okay. Now, I mentioned H. pylori. Remember that H. pylori is associated with gastritis and the development of ulcers and even gastric adenocarcinoma, gastric B-cell lymphoma, and MALT. So it plays a critical role in the pathogenesis of peptic ulcers and in cancers. And if you eradicate H. pylori, it can even cause regression of certain cancers, which is why the H. pylori eradication is important. So when we find a patient who tests positive for H. pylori, it's important that they undergo treatment. So how do we treat H. pylori? So we have the OCA therapy, which is the triple therapy of omeprazole, clarithromycin, plus metronidazole or amoxicillin. However, if, for example, a population has been shown to have quite a high resistance against clarithromycin, we then switch to quadruple therapy, which is omeprazole, bismuth subsalicylate, which I discussed previously, is not just a mucosal protective agent, but also has the added benefit of being antimicrobial, metronidazole, and your tetracycline. And this is the regimen that is used in H. pylori eradication. So omeprazole, why do we give it in H. pylori eradication? Obviously, in addition to being a proton pump inhibitor, meaning it will give ulcers time to rest and heal, it actually has been shown to also enhance or improve the effects of your clarithromycin and amoxicillin in attacking your H. pylori. So let's go into some practice questions. Long-term use of omeprazole has been associated with which of the following side effects? Fractures, hypocalcemia, pneumonia, or all of the above? So our answer is all of the above, okay? Where does absorption of oral omeprazole occur? Is it in the antrum of the stomach, the ileocecal junction, the small intestines, or the large intestines? So wag malito, remember, activation is in the stomach, but absorption is in the small intestine. So these questions did come out. So remember, activation in the stomach, but absorption is in the small intestines. So we've discussed your medications for your peptic ulcer disease. Let's now move on to the prokinetic agents used in gastrointestinal pharmacology. Okay, next we discuss your prokinetic agents. So as always, I like to discuss why and how these drugs work before going into each drug. So when it comes to the movement of your gastrointestinal system, remember that we have what we call motilin, okay? So this is a peptide hormone that stimulates motility, as the name suggests, motilin, in the proximal gut. So it causes a contraction of the proximal gut, thereby propelling its contents caudad or towards the anus. So in the fasting state, when we're not eating, we get what we call MMCs. So this should, I'm sure this was covered in your physiology. These are your migrating motor complexes, and their function is to propel bacteria caudad or towards the anus during the fasting state. And during the fed state, we have, of course, simple peristalsis, which causes propulsion of the food forwards, or it can also not propel the food forwards, but only occur statically just to mix the food together. So if motilin promotes motility, from the name itself, dopamine inhibits motility. Okay? So motilin promotes motility, dopamine inhibits motility. So how does it do this? Dopamine inhibits motility by inhibiting the secretion of ACH released from your myenteric motor neurons. So remember, ACH is something that is released during parasympathetic stimulation, during rest and digest, and it is necessary for smooth muscle contraction. Therefore, if you inhibit the release of ACH, you get less smooth muscle contraction. Therefore, you get less movement in your bowels. So therefore, if we want to have prokinetic, meaning we want to move our bowels, we have to either increase the motilin or decrease the dopamine. Okay, so how do we do this? Just erase this. So there are several drugs that we can give. So the two drugs we can give to inhibit dopamine are your metoclopramide and your domperidone. So they are D2 receptor blockers. So remember, metoclopramide and domperidone are D2 receptor blockers. And conversely, we can then stimulate motilin through giving erythromycin, which also stimulates motilin receptors. Erythromycin, as we know, is a macrolide antibiotic. However, it has that side effect as well. Kaya diarrhea ang isa sa mga side effects ng erythromycin. Metoclopramide and domperidone are the drug of choice for diabetic gastroparesis. Ano nga ulit yung pathophysiology behind diabetic gastroparesis? Remember, diabetics, they typically have some level of neuropathy, and this includes their gastric system. So because of the neuropathy, they are unable to fully detect whenever they have stretching of their gastric lumen. Therefore, they are unable to initiate peristalsis that well. Therefore, they get gastroparesis. Parang nag-paralyze yung kanilang gastric muscle, so it doesn't stimulate contractions as well as it should. It is also used as antiemetic for post-operative vomiting. However, what else blocks D2 receptors, diba? These are also your antipsychotic drugs. And remember, with antipsychotic drugs, we get side effects like your extrapyramidal symptoms, your Parkinsonism, and your hyperprolactinemia. So just a quick physiology recall, the reason we get hyperprolactinemia whenever we block dopamine receptors is because dopamine tonically inhibits the secretion of prolactin from your pituitary gland. Therefore, if you inhibit dopamine, you get hyperprolactinemia. Okay? That's why metoclopramide should not be given chronically. Again, especially with elderly patients, they are more prone to these side effects. Domperidone, however, does not cross the blood-brain barrier, so it's less likely to produce these side effects. Why do we give erythromycin and when do we use it? So we can give erythromycin especially before an endoscopy kasi what it does is it can clear out any debris from the upper GI tract and it allows us to visualize whatever we're looking for more clearly during an endoscopy. Okay. Next, we have your laxatives. Okay. So patients who are constipated, they will have several different definitions for constipation. It can be either decreased frequency, difficulty in initiation, or passage of firm or small feces, or feeling na may natira, or what we call incomplete evacuation. So first line usually is non-pharmacologic interventions. We advise hydration, we advise exercise, we advise a high-fiber diet. The next first lines would be to try an osmotic or a bulk-forming laxative agent. So what are your osmotic agents? So from the name itself, what it does is it pulls fluid. Okay, it pulls fluid into your lumen, into your colon lumen, and this causes an obligate increase in fecal fluid, therefore allows you to have a smoother bowel movement. So perhaps the most well-known one is your lactulose. Okay, so those are the ones you need to remember. We also have your bulk-forming laxatives from the name itself. It forms a bulky gel inside your colon. This distends your colon and this promotes peristalsis. And the most famous one is your psyllium husk, which you can buy over the counter as well. There are also other agents that we can use. So we can give stool softeners, such as your docosate. So what they do is it acts like a surfactant sa surface ng poo to allow more water and fatty substance to enter the poop, makes the poo softer, and it allows you to empty your bowels a bit quicker or a bit better. Next, you have your stimulants, your bisacodyl, your senna, and your castor oil. So these agents directly stimulate the enteric nervous system to promote peristalsis. This can cause melanosis coli, which I'll show in the next slide, especially with senna. And another problem with stimulants is medyo indiscriminate yung loss mo of water and electrolytes. So you can get dehydrated and have some electrolyte imbalances with chronic stimulant laxative use. So this is what melanosis coli looks like. It's seen on colonoscopy as pigmentation of the colon. And in patients with laxative abuse, for example, people who are bulimic, so they want to purge whatever calories they take in by taking laxatives, or patients who are chronically constipated and are chronically on senna, you can see melanosis coli. Okay. Next, we have your antidiarrheals. So whenever we have diarrhea, usually our advice is not to use any loperamide. It's best to just clear the system of whatever it is that is causing the diarrhea. But sometimes, let's say the patient has a very important event to attend, or you're taking the boards and you want to make sure that you don't waste time by going to the bathroom, or you don't feel rushed while taking the exam. Sometimes we take a loperamide. So what are your options for your antidiarrheals? You can take an opioid or a non-opioid option. So a loperamide is actually an opioid. It activates your mu-opioid receptor. And in terms of its effect on constipation, because it causes constipation, right? That's essentially what it does. It's 40 to 50 times more potent than morphine when it comes to the constipation side. So what it does is it slows motility via the mu-opioid receptors in the enteric nervous system. And there are two options, loperamide and diphenokylate. So lumabas sila both in the previous board exam. So do know both, loperamide and diphenokylate. Loperamide acts only peripherally, okay? So it does not cross the blood-brain barrier. However, diphenokylate is a Schedule 5 controlled substance because it acts on the central nervous system as well. It is able to cross the blood-brain barrier and has CNS effects similar to other opioid drugs. So it is actually prone to addiction and dependence. Kaya it is co-formulated with atropine to prevent or counteract addiction. So, okay, diphenokylate is given with atropine. The available preparations is always with atropine. There are also non-opioid options, kaolin plus pectin and colloidal bismuth. So remember, bismuth is one of your mucosal protective agents, and I mentioned it can reduce stool frequency in acute gastroenteritis. So kaolin and pectin is an adsorptive agent, so it absorbs water and bacteria to create firmer stools and reduce fluid loss from diarrhea. Bismuth naman reduces stool frequency as discussed earlier. So ang high yield talaga dito are your loperamide and your diphenokylate. Make sure you know those two drugs. Okay, remember they are opioids. Loperamide peripheral, diphenokylate central, crosses the blood-brain barrier, which is why we give it with atropine. Next, let's talk about your antiemetics. So again, I always try to discuss what happens with vomiting anyway. So your vomiting center is found in the medulla, and it receives several inputs from different parts of your body. So it receives inputs from your GI tract in the form of serotonin or 5-HT3. It receives inputs from your cortex or your thalamus whenever you perceive anxiety or pain. It receives input from your vestibular system, your inner ear system, whenever it detects abnormalities in motion. And it does so via your histamine and your muscarinic receptors. And it receives a lot of input from your chemoreceptor trigger zone, which is a part of the brain that is not covered by a blood-brain barrier, and therefore it is able to detect any emetogenic substances in your blood. It has receptors for opioids, for dopamine, for neurokinin, and they all transmit signals into the vomiting center to tell you that you need to throw up. There is something that's toxic, there is something that is disturbing your body, and you need to get rid of it ASAP. Now, the most important antiemetic perhaps for the boards are your 5-HT3 antagonists or your serotonin antagonists. The most familiar to you will be your ondansetron, but there are several other serotonin antagonists, your granisetron, dolasetron, palonosetron, allosetron, and tropisetron. So remember, the 5-HT3 is found in the chemoreceptor trigger zone. It receives this input usually from the GI tract. It is very, very effective in the use of managing post-chemotherapy nausea and vomiting. So why is it most effective in post-chemotherapy nausea and vomiting? During chemotherapy, serotonin is released by your enterochromaffin cells of the small intestines, and this stimulates the vagal afferents to initiate the vomiting reflex. So it is serotonin mediated. So by inhibiting your 5-HT3 or by antagonizing your 5-HT3, you are able to reduce this effect. So what are some side effects of your 5-HT3 antagonists? Allosetron in particular causes constipation, whereas the rest of them cause diarrhea. So study smart, just remember allosetron causes constipation, but the rest cause diarrhea, okay? It can also cause some headache and dizziness, and dolasetron in particular is associated with ECG changes, particularly QRS and QT prolongation. So what are some other antiemetics not on the slide? So I remembered, I mentioned neurokinin is also one of the things that can trigger emesis. So a neurokinin antagonist is aprepitant. And you also have some histamine receptors in your vomiting center. So things like cyclizine and diphenhydramine are antihistamines that can also help with nausea and vomiting. Okay. Next, let's move on to the discussion of your inflammatory bowel diseases. So remember, you have two main forms of IBD. You have your Crohn's disease and you have your ulcerative colitis. Crohn's disease, diba, affects the entire GI tract, and it is not a continuous affectation of your GI tract. It presents with skip lesions. So certain parts of the GI tract are affected, certain parts of the GI tract are spared, but it involves the whole GI tract. Your ulcerative colitis, from the name itself, colitis only affects your colon. It does not involve your small intestines, your gastric lining, etc., etc. Both of them are a result of excessive inflammation in the system against the cells of your GI tract. And so they are treated quite similarly. There are a few differences in how they are treated, but generally they follow this sort of triangle or this hierarchy of how we treat them. So starting at the bottom of the pyramid, which is the treatment for the mildest forms of your inflammatory bowel disease, we have some budesonide, which is used for ileitis, topical corticosteroids for proctitis, antibiotics, and your 5-aminosalicylates, which I'd also discuss in the DMARD section of pharmacology. When it's moderate inflammatory bowel disease, this is when we step up to your biologics, like your TNF antagonists. Your corticosteroids are now oral. We can give methotrexate, okay, and azathioprine or 6-mercaptopurine, which are some of your immune modulators. And if it's very severe, we can treat it with surgery, although note, there is only one of these two that we can treat with surgery. Can you guess which one of these two is treatable with surgery? Crohn's versus ulcerative colitis. So looking at the picture, alin dito yung pwede i-resect versus hindi kaya i-resect? So ulcerative colitis, because it only involves one part of your GI tract, continuous siya, you can resect it. Versus in Crohn's disease, hindi naman pwede na we pick and mix just very small sections of the bowel to resect. So ulcerative colitis can be treated with surgery, but not Crohn's disease. We can also use natalizumab, another monoclonal antibody, and some more medications, which I'll discuss in the next slide. So again, let's start with the mildest form of treatment, your mesalamine or your 5-ASA-based therapy. This is more effective in ulcerative colitis than it is in Crohn's. So why is this more effective in ulcerative colitis? Typically, this mesalamine is given topically, meaning it is given per rectum. And remember, what is the inflammation in ulcerative colitis versus Crohn's? Alin sa dalawa yung transmural inflammation? Diba, it's Crohn's. Crohn's has transmural inflammation. Because it is a topical effect, it cannot fully penetrate. It cannot penetrate transmurally. Therefore, it is unable to inhibit inflammation through all layers of the bowel. Therefore, it is more effective in ulcerative colitis. What is the mechanism of function by which it works? It inhibits IL-1 and your TNF-alpha, which we know are inflammatory mediators. Your glucocorticoids, we know that they reduce inflammation, and the most commonly used steroid in IBD is your prednisone. So this is only good in inducing remission, meaning if somebody has a flare, we give a course of steroids to force the body into remission, but we do not give it long-term. Again, as much as possible, we try to avoid giving steroids long-term because it has several side effects. The particular steroid also that we can use is budesonide for Crohn's disease, particularly for ileocecal Crohn's disease. Then we have your immunomodulatory agents, your thiopurine derivatives, your azathioprine and your mercaptopurine, which we know inhibit cell proliferation, and your methotrexate, your folic acid inhibitor, your DHFR, dihydrofolate reductase inhibitor, all of which prevent the proliferation of your immune cells. Now, if it's very severe, we do step up to your biological therapies, and the ones you need to know are your infliximab, adalimumab, and certolizumab, okay, your anti-TNF-alpha, your vedolizumab, blocks lymphocyte addressin binding, and your ustekinumab is also used in the treatment of Crohn's disease. So remember, uste has their paskuhan on December 23, 12/23. So it's anti-IL-12 and anti-IL-23. Now, if a patient presents to you with a known inflammatory bowel disease, complaining of gastrointestinal pain or abdominal pain, and requesting for an NSAID, remember, we do not give NSAIDs in patients with IBD. It makes everything worse. So NSAIDs are strongly contraindicated in IBD. Okay? So let's go into some practice questions. How does loperamide slow down GI contraction? Serotonin antagonism, opioid receptor activation, stimulation of the sympathetic system, or anticholinergism? Remember, it is a mu-opioid receptor agonist. It acts on the mu-opioid receptors in the myenteric plexus of your gastrointestinal tract. Difenoxylate is given to a patient with diarrhea. Which of the following side effects can be expected? Is it A, respiratory depression, B, tachycardia, C, diarrhea, or D, respiratory alkalosis? So it is respiratory depression. Remember, difenoxylate, it's a flying ox. It can cross the blood-brain barrier. It can enter the CNS, and it can cause the CNS effects of your opioids, which include respiratory depression. A patient with poorly controlled diabetes complains of early satiety, belching, and regurgitation. Which drug can you give? Can you give ranitidine, omeprazole, sucralfate, or metoclopramide? Perhaps the best question would be, what drug should you give? Because technically you can give all of these. But the best answer here, first, what is the patient complaining of? Diabetic, symptoms of dyspepsia, symptoms of delayed gastric emptying. This is diabetic gastroparesis. And in order to counteract diabetic gastroparesis, we have to give a prokinetic agent, which is your metoclopramide, again, a D2 antagonist because dopamine inhibits peristalsis. What's ranitidine? It's an H2 receptor blocker. Omeprazole is your PPI, and sucralfate is one of your mucosal barrier agents. Select the biologic agent used in the treatment of ulcerative colitis. Is it azathioprine, mesalamine, infliximab, or your prednisolone or your prednisone? You can answer this just by using testmanship alone, which is the case for a lot of your board's questions. The question is asking for a biologic agent. Alin lang dito yung biologic agent? This is the only drug ending in mab, monoclonal antibody. Therefore, it is your infliximab or your TNF-alpha inhibitor. Okay. Management of Crohn's disease includes all of the following except sulfasalazine, surgery, immunomodulators, or steroids. So as mentioned earlier, only ulcerative colitis can be treated with surgery. Crohn's disease, because it has skip lesions, it's not just located in one area. It's sort of scattered throughout the gastrointestinal tract. It cannot be treated with surgery. So the answer is B, surgery. And that's it for your gastrointestinal part of the pharmacology lecture.